You good? So my name is Meredith. I'm going to be talking today about pediatric tracheostomy management. I'm a master's degree student at Drexel University. This is part of my capstone teaching project, so almost done. I work at AI DuPont Hospital for Children. I'm on a respiratory ortho rehab floor, and we have a large pediatric trach population. So we do a lot of trach education with parents as well as other nurses. And before I worked at AI, I did work here on MG1. So I worked with adults first and then moved into peds, thank God. So the objectives for the presentation is to identify the signs of a tracheostomy emergency, demonstrate how to suction a trach, and perform a tracheostomy change according to hospital procedure. So everybody knows respiratory anatomy, but just to kind of go over it real quick, we have the upper airway and the lower airway. The upper airway is going to be your nose, your mouth, epiglottis, pharynx, and larynx, and then your lower airway, your trachea, bronchial tubes, lungs, and alveoli. And then we all know how to do a respiratory assessment, but it's kind of the basic part of taking care of a trach. So you have your respiratory rate, rhythm, work of breathing, lung sounds, your pulse ox, perfusion, and behavior. We're going to dive in a little bit on each of these quickly. So starting with respiratory rate, it's going to go off of your age when you're working in pediatrics. And as kids get older, their respiratory rate gets lower and becomes more towards an adult in their late teenage years. And then a baby is 30 to 53, and it's kind of difficult to check a baby's respiratory rate when they're screaming and crying because they're scared of you. But so respiratory rhythm and work of breathing. So your rhythm is the regular cycle of inspiration and expiration. Hopefully it's regular. You can be apneic or have some apnea. Work of breathing is the use of accessory muscles. So you have retractions. So the four I have listed up there is supraclavicular, which is going to be the inward drawing of your skin above your clavicle. Intercostal is in between all of your ribs. Substernal is right below your sternum at the xiphoid process. And then subcostal is all along your costal margin. You can have nasal flaring as well in kids. So then lung and breath sounds, just to list a few, we have clear, crackles, rhonchi, and wheezes. Breath sounds can be equal or unequal. You can also have audible noising when you're breathing. If you're having some respiratory distress. And then this picture over here I thought was really good, showing the intercostal retractions. You can basically visualize each of the little kids, the baby's ribs. So pulse ox, perfusion, and behavior. Pulse ox is going to provide information about your patient's oxygenation saturation. Perfusion, if they're warm, if they're cool, if they have any pallor, if they're pink, cyanotic. The earlier sign of cyanosis is going to be peripheral cyanosis, so around their nail beds, their lips. Do you have a question?
Oh, I do. So for a patient with a trach, a child, do they have the same presentation as an adult? Like, does their skin color and the coolness change exactly like an adult, or are they a little different because they're pediatric?
They can seem a little different. Sometimes you can have a kiddo that's a lot more pink than an adult might be if they're having some respiratory distress. So the initial presentation could be a little bit different.
Oh, thank you. I haven't had a lot of experience with that. Thank you.
And then, so a later sign of respiratory distress could be like a more central cyanosis. And then behavior changes is huge in kids. Any changes in their activity level, any increased restlessness or irritability. Another one for younger babies is if they're having any difficulty feeding. So if they're like drinking from a bottle and they pull back and gasp, that might be a sign of respiratory distress. And then end tidal CO2. So this is important when you have a very acute patient. It's great for checking if the airway is placed. That was good. So it's essentially the measurement of the CO2 that you're exhaling off. It's a sign of ventilation, whereas pulse ox is going to be more of an oxygenation. So it's great to confirm where the trach is, if the trach is placed or any advanced airway is placed. If it's lower, then you're going to be hyperventilating, and your end tidal is going to be less than 35. Normal range is 35 to 45. Elevated is going to be a hypoventilation. So what is a tracheostomy, why we're here? It's a tube inserted into the neck through the trachea, below the larynx. And it's used for patients who need prolonged respiratory support. So this could be to bypass a blocked airway, to provide prolonged mechanical ventilation. So reasons that this could be CNS or neuromuscular disorders, any type of trauma or pulmonary disease. BPD is big in the little guys that get trached. And then any type of congenital abnormality of their upper airway. With traumas, that can kind of vary on if they will be trached for a long time versus a short time. I work a lot with spinal cord injuries and brain injuries, and a lot of times the brain injuries, when they have a decreased level of consciousness, will be initially trached, and then as they go through their rehab stay, we do see them decannulated before going home. Spinal cord injuries kind of varies on where their injury was. If it was a cervical injury, chances are they're going to be trached. So with the trach, you're breathing through the trach rather than your nose and your mouth, so the air is not warmed, cleaned, or moist. So we have to use different types of equipment to provide that for the patients. So trach collars are huge in the hospital if they don't need any respiratory support, otherwise they might be on a ventilator. We also have HMEs, which is like a portable trach collar. Basically cleans, moistens the air. With an HME, patients, if they have a lot of secretions, they can cause their own mucus plug because they're not coughing this off typically unless they have a very strong cough. So we don't normally leave patients by themselves on an HME. HMEs can provide oxygen too, so you can hook this up to your oxygen, pop this on the trach. It's great for kids that are actually on the go. So like I said, working on a rehab floor, we're sending them to the gym all the time. So they're typically on HMEs, and then humidification through the vent, like I said. So it's inserted below the larynx, so they're unable to vocalize. So in order to do that, unless they can talk over their trach, if their cup is deflated, which some do, we use Passimir valves. So I have two different ones here. This is just your basic one. When you use a Passimir valve, you have to have the cup deflated because even though they're inhaling through their trach, they're exhaling through their nose and their mouth. So if the cuff's inflated, they're not going to be able to exhale. So that helps them talk. And then we do have them too that you can put some oxygen on that if they need it. This is usually initiated with speech therapy since it is a different way for them to be breathing. I had one patient one time tell me it was like breathing in and out through a straw, so they kind of got to work up stamina with it. Passimir valves don't have humidification, so their secretions can be thicker. They can get more secretions if they're on them for a while. And then this is a picture of a trach collar, and it's basically just based on the manufacturer what they would look like. So parts of a tracheostomy, I have them all labeled up here. This is a Bavona trach, which is the most common that I have seen in pediatrics. There are different types, but essentially they all have the same parts. So starting with the obturator, this sits inside of the trach and provides a smoother insertion because it's a rounded edge, and it helps to avoid tissue damage when you're inserting. And we just have the connector, which is just the end of the trach. The flanges are on either side, so you can put the trach ties through each of the holes. If it is a cuffed trach, it's going to have a balloon on the end, and this is going to cue you into if the cuff is inflated or deflated. And then with Bavonas, we just have one cannula, as opposed to like Shileys have inner and outer cannulas. So we just have the one cannula, so this means that when you have to change the trach, you're changing the entire trach out rather than just the inner cannula. And then trach wedges come with every new trach basically, and it just helps get anything off of the connector that would be put on. So sometimes it can be tough to get like a vent off of the end of the trach to suction. Oh, and then actually the cuff is at the bottom of the trach, which, let me see if I have my bigger trach, you can kind of see when it's actually inflated. And so then it's just a balloon on the end of the trach. And that's just going to provide more respiratory support for the patient. So daily care, I know you don't perform daily care in the ED necessarily, but just to kind of review the basics of it. Skin and stoma care, so you're going to check for breakdown around the stoma and under the trach ties. This is important with any trach assessment because you want to make sure that there isn't any breakdown. It could be a source of infection for the kids. The tie changes are done once a day or whenever the ties lose their integrity, so this could be because they get wet. So whether it's through bathing, if they're sweaty, if they're pooling a lot of oral secretions that are leaking out, you just want to go ahead and change the ties rather than just trying to tighten them. They should be tight around the neck. but loose enough to fit one finger in between the ties. So as you can see in this picture over here, that's what's going on, which can be a lot of fun when you're teaching parents who the dads have real big fingers and then the moms can be like me with tiny fingers. So you work with them to kind of figure out the exact tightness. And then suctioning, which will be our next slide. So suctioning clears the tracheal secretions. You have to use the appropriate catheter size, and this is going to be based off of your trach size. So if you have a 6.0 trach, you're going to multiply it by 2, and you're going to use a 12 French catheter. Or like my little baby trach over here is a 2.5, so it's a 5 French catheter that we have, and they're super teeny tiny. If you have a half size trach, so like a 5.5, you can go up or down. If you don't have like an 11 French catheter, you can use a 10 or a 12. It's better to go up though, because that's going to just give you more respiratory clearance when you're suctioning. And then how deep you suction is based on the trach size as well. So that's another big difference between pediatric and adult trachs, is you don't just suction till they cough. You actually want to insert the catheter so it's coming into 1/2 centimeter to 1 centimeter at the end of the trach. And then you'll see on the edge of the catheter the marking. So this would be you suction to 6. You can also do it with an obturator if you don't have a spare trach, but you have their obturator, which should really always be with them in case they decannulate. But if you're measuring on the obturator, you're really just measuring the length of the obturator from this piece down, because this is sticking outside of the trach. So that would be another way to do it. So to suction, you're going to gather all your suction supplies, and then I do have handouts for them, for the supplies needed. So suction catheter of the appropriate size, and then your suction source, which you want to be set to the appropriate pressure, and that's going to vary on the kid's age. So if it's an infant, it's going to be 60 to 80. With a kid, it's 80 to 100, and then adults are 100 to 120. So just because you want to crank up the suction because they're very junky, you don't necessarily have to. It might cause more damage than good. So you want to hyperoxygenate the patient, so you want to use a bag. Give them a couple extra breaths before suctioning. Connect the suction to the catheter to the suction source, obviously. And then make sure the suction source is on. So there's some recommendations. Some people say to have some sterile water to actually test that the suction's on if you need to. When you remove the catheter from the packaging, you just want to make sure that the end, whatever you're going to be placing inside the trach, is not like flying all around the room and touching different surfaces. Even though this technically isn't like a sterile procedure, you want to try and use sterile technique in terms of keeping that part of the catheter clean. And then as you insert the suction catheter, you want to insert it to the ordered measured depth that we just went over. And then while removing it, apply suction while twisting the catheter. So why would you twist the catheter as opposed to just inserting it and removing it? Does anybody have an idea? So I used to not twist the catheter, but when I went to peds, it can, you get more of the whole diameter of the trach, of the cannula. So on this, and it's so tiny, but there are holes that are a little bit staggered. So you might get most of the trach, but if you twist it, then you're guaranteed to be getting the entire diameter of the cannula, and in turn have a better suctioning pass. So then you want to assess the outcome of your suctioning. Is your patient, is their pulse ox better? Are they coughing less? Do they seem more comfortable? You want to pay attention to the secretions as you're suctioning out, the quality, the quantity, the consistency of the secretions, and if it has been a change since the last time they were suctioned, and if so, how long the change has been. And then if you're suctioning a patient a lot, you do want to give them a break between passes to kind of let them recover, because you're essentially taking their breath away as you suction. So giving them like a minute to kind of have some deep breaths. You can bag them. After you suction about like 3 times, you do want to give them a decent amount of break in between, a couple more minutes than just 1, unless it's an emergency, in which case you can keep on suction. And then I have just a video about suctioning.